My name is Dr. Jeremy Larsen. I am a multiple myeloma specialist here in the Department of Hematology and Oncology, and I'm tasked today with reviewing a little bit about some of the changing paradigm in multiple myeloma. Really, I think this is the poster child for progress in cancer across the board, and so it's an exciting time from a perspective of new therapeutics. And really, I believe we're kind of in the wave of some very, very powerful steps forward, especially with some of the immunotherapies that are in the pipeline. So I'm scanning the list of our participants here. I recognize some names that look very familiar here. So it looks like at present we've got a good core group here. And so just again to kind of reiterate from a perspective of the goals of the session, absolutely want this to be as interactive as possible. I'll kind of give you a little bit of a sort of a highlight, sort of a high view, if you will. The myeloma 101 really in terms of a broad overview. And I know all of us are at sort of different phases of the journey here, but we'll absolutely be able to then, to kind of dive into specific questions as we go here. Okay. And so from a perspective of, really the initial, diagnosis of multiple myeloma, I think this is the type of condition that unfortunately, can many times fly under the radar for a number of years before, ultimately making the diagnosis of this condition. At its heart, this is a bone disease for many patients. And so unfortunately, a common presentation is new pain or even fracture because of the effect the myeloma can have on the skeletal system of the bones, specifically the spine and some of the long bones that unfortunately can be at risk of fracture. This is a particularly I would say unique type of disorder in the fact that it tends to have a precursor, meaning a kind of pre-malignant state, if you will. I always like to think of this as almost like a colon polyp of the blood. That's not a perfect analogy, but I think it's something we can all wrap our mind around in terms of why we do colonoscopies to find something that's early. In multiple myeloma, it tends to be what we call a monoclonal protein, which is a fancy term for meaning an excess type of one specific protein, and these are termed immunoglobulins. Another easier way to think about this is an antibody, but instead of being a functional antibody or the full spectrum of these proteins, our body is overproducing one specific type. So I sometimes like to imagine the finger stuck on the on the copy machine start button, and so we're spitting out blank copies of one specific protein. The protein in and of itself oftentimes can be detectable in up to 3 to even 4% of patients up to over the age of 65 or so in the of individuals with Caucasian background, and this actually can be higher incidence even if we look into, for example, Ghana and some other areas in Africa where the incidence is even higher than that, but patients are asymptomatic and it does not cause problems. And so the issue arises when what we call monoclonal gammopathy, these cells gain a competitive advantage and additional genetic mutations and can start to behave in a cancerous fashion, which leads to a lot of the common symptoms that we see in multiple myeloma. As I mentioned at the start, commonly bone disease. Unfortunately, this is something that the protein can adversely affect the kidneys. So we can see things like kidney damage. Hopefully, when the diagnosis is made, this is early enough where it's able to be detected and treated, so that long-term kidney damage is not seen. But unfortunately, some patients do experience irreversible injury or damage to their kidneys, and that's certainly something we want to avoid. Thinking about other markers, classic manifestations can be low hemoglobin or low red blood cells, and so sometimes the diagnosis is made by, for example, an astute primary care physician who notices on a routine checkup someone's red blood cell count is lower than expected. They look for other common causes and they all check out okay, and this can be something that leads them to look for specifically multiple myeloma. The challenge is that unlike, let's say, prostate cancer or breast cancer or colon cancer, as of 2020, there is not a commonly used screening test for this condition, and largely that's due to the fact that it's a less common type of cancer. So this is about 1% of all cancers. So compared to lung or prostate, et cetera, we're talking about a small sliver. But that said, about 30,000 individuals per year in the United States are diagnosed with multiple myeloma. So this is not an insignificant, disorder. It's the second most common type of blood cancer behind lymphoma. And so I think this paradigm may start to evolve, and actually there are some really fantastic studies that are currently ongoing that Mayo is collaborating with, especially for the higher risk group. So perhaps if you look at across the board, all individuals, maybe not everyone needs screened for this, but for example, let's say you have a brother or you have a parent who had either this known monoclonal gammopathy condition, kind of the precursor condition, if you will, that many times does not need treatment, or multiple myeloma, then this is the patient population perhaps that really would benefit from a screening and more of a preventative type approach. And so if anyone's is curious about any of that information, I'm happy to give you some of those details, but much of this can be initiated actually by patients or family members themselves, with test kits being sent out, pre-addressed labels. They head back, and we're really trying to learn both from a perspective of why this monoclonal gammopathy happens in the first place. What are some of the hereditary features of this, if you will? And what is the immune system doing in all of this? At the basis of all of this, this comes from our our immune cells. These are antibodies, and we all make them. So this is kind of a mutated version of something normally all of us do, and also trying to understand who really would benefit from screening. How often does, let's say, how can we pick this up incidentally in someone with a primary family member with a history, and can we really avoid some of these end-stage complications? So that's a little bit about the the monoclonal gammopathy piece. I have a few slides, and I won't belabor you with lots and lots of PowerPoints, but I think sometimes to envision the spectrum, this, we can walk through this. But essentially, the monoclonal gammopathy, if you imagine, across the United States, there's millions of people walking around with this, and actually many of them don't have any idea that it's there, since it's not something that shows up on routine, testing if you're just going in for your annual checkup. Looking at this sort of, I kind of think of this as the teenager, or this sort of intermediate condition. There is a term that is termed smoldering multiple myeloma, and so this is something that we have all of the hallmarks of the disease. The cells in the bone marrow where they live are there. We have a high amount of the protein in the blood, but remarkably, there are no symptoms, meaning, those things we were talking about that we oftentimes use this acronym of CRAB, or mnemonic. It's a nice way to sort of keep this in mind, but C being calcium, so high calcium, as this can be released inappropriately from the blood by these cells, leading to very high calcium, which in and of itself can cause many symptoms, but can cause kidney injury, et cetera. In addition to that, if we kind of think about this smoldering multiple myeloma, if we imagine what is the incidence of this moving into multiple myeloma, if we sort of say year by year, on average, it's about 10% of patients in that smoldering myeloma group may go on to form symptoms for those first 5 years. So at the 5-year mark from when this is recognized, about half of patients, unfortunately, have moved into that symptomatic myeloma category of sort of the high calcium, the R of that CRAB being renal, meaning kidney, so kidney injury, the A being anemia, and the B for bone lesions, as we can see some of these on x-rays. And I'll show you again a couple of other ways that we commonly look for this nowadays with more sophisticated imaging. But if we're in that smoldering myeloma category at this point, typically we would not treat that, and that's been the paradigm really going on the last 30 plus years. Despite many efforts for early intervention, I think we're right in the middle of, again, kind of a paradigm shift in terms of, we now do have clinical trial evidence that some of these newer tools that are now available to us really can, when you use them or apply them to earlier on, hopefully help significantly reduce the risk of progression to symptoms, which at the end of the day, obviously is very, very important. Some of the data that we continue to wait for that will also be a very important thing that will factor into who needs treated. how does it long-term affect survival? So some of the earlier trials that have looked at intervention before symptoms in this condition of smoldering myeloma have been, I would say, limited by a few things. One important one is that some of these treatments historically were hard to tolerate. And so if you imagine taking someone who is asymptomatic and very quickly making them symptomatic by giving certain medicines that can cause just chronic, I would say, reduction of quality of life. So things like constipation and fatigue and neuropathy and diarrhea, et cetera. These obviously that's a hard thing to do. If you're coming from a pretty good quality of life to suddenly, a very impaired one. And so there was the tolerance. So we just didn't have the right tools. So as the medications, the therapies have gotten much better, much more, I would say, rationally designed, biologically driven targets. The side effect profile in general has become friendlier. But I think the other big limitation with this was really trying to define who are the patients who are at the highest risk, because we know many patients with smoldering myeloma, despite that 10% per year in those first 5 years, after those first 4 to 5 years, the risk that this goes on to cause symptoms starts to flatten out. And so, I think that if we think about the first sort of rule of medicine, do no harm, I absolutely do not want to, expose someone who otherwise would never be bothered by this to potential risks of therapy. So it's been very, very actively investigated in the field of who really are the patients who need a treatment. And over the last, I would say, decade, a number of prognostic studies have helped to clarify, who is this high risk group. We used to use a term what we called ultra high risk smoldering myeloma, and this was trying to really say the small group, about 10 to 15% of patients who we could kind of see them headed towards trouble, but we still didn't call them myeloma, and so historically they weren't treated. So if we kind of go back to right around 2015, 2016, actually the diagnosis criteria of myeloma were completely revised. And so for the first time, the definition of myeloma actually incorporated a group of patients who were still asymptomatic, but they had biomarkers, meaning something in their blood or something on their radiology imaging via an MRI or a PET scan, for example, that suggested basically in the next 2 years, 80 to 85% of those patients were going to go on to develop symptoms. And so the very, I think consensus decision was that this is not a group of patients you want to kind of watch. And so actually this has led to the incorporation of a few new ways that we define myeloma. It applies to a very small group of patients, but that said, it really goes to show that the therapies, since we don't have as high of a barrier for entry, if you will, because the side effect profile has changed so much over time, there's a lower threshold, that might push you to treat someone. At the same goes that as the medications have improved, the benefit has substantially risen in terms of now we realistically can talk about, can we cure some patients with multiple myeloma? And I think that's really where, as we're in this new decade of 2020, that this conversation can be, it's not a dream. We need improvements in testing and the ability to detect really, really low level disease, and so to be able to make those adjustments or slight tweaks in therapy when someone is very close but not quite there. And the same thing goes that there are patients who have eradicated the disease, perhaps that you can actually hold therapy. And right now we're not quite to the point of having those extremely sensitive tools, but that will be a huge step forward. And I think we've all seen an explosion of new biologically driven medications that attack the myeloma in unique ways. There are a number of Achilles heels of these cells. And I think one thing that's unique about myeloma is that really the drugs, the medications we use in this are fairly unique to this disease. If I have nothing against my medical oncology colleagues, but some of the medications that are used, for example, in lung cancer or a throat cancer or a breast cancer, many of those same medications are used across the spectrum as they sort of kill fast, dividing cells. Whereas in myeloma, really many of these therapies are specific to the biology of what we call the plasma cell, which is the mother cell of a myeloma cell, and at its heart, these are little protein synthesis factories. And so trying to figure out how do you shut down that factory, and really diving deep into the science over the last two decades especially have really led to a complete change in the prognosis and long-term outcome in this particular condition. If we go back to the late 1990s, this was, unfortunately a condition that there were a few therapies that could be used. Most of them were fairly toxic and chemotherapy based, so a fairly high side effect profile. And there just weren't a lot of options. And so after maybe the first go round or second go round, unfortunately, many patients within 2-3 years, lost their lives to myeloma. Whereas now, and we can confidently say, and as we look at our data at Mayo, for example, many things that if we kind of say, defining the prognosis, we know the genetics are much more clear, so we can identify that minority of patients with multiple myeloma who have high risk disease, and so that can help tailor a personalized therapy for that group. But for the standard risk patient, which applies to most individuals at the start of this, essentially, this would be the type of thing that, if we were to say someone was transplant eligible, which you kind of think of in a common sense fashion, really what this basically would mean is someone whose get up and go is good. Their vim and vigor, as I like to think about this, is something that can stand up to some of the side effects of the treatment. It's a powerful punch of a one-time dose of chemotherapy, so the side effects are high enough that this is not going to be reasonable for all patients. But generally, if we would say age is less than 75, otherwise medical health is reasonable, they have good caregiver support, a transplant or a high-dose chemotherapy and a stem cell rescue is one of the time-tested ways that we know can help prolong period of remission and deepen the response, meaning driving the myeloma down as far as we can go. It's one of the most helpful tools. So with looking at several short months of kind of induction, which I think of as sort of putting in our best players first, drive down the disease, followed by a stem cell transplant. And this is the paradigm as of 2020. This may change in the near future. And then generally some sort of a maintenance therapy. This would be something that I would expect to 10-ish years of overall survival. And that's really, I think, it's something that's constantly evolving. So I think hopefully in the next several years, we will actually start to definitively, say we are curing more patients. But as of right now, we see a prognosis that's gone from 15 years ago, 2 to 3 years, perhaps, now we're talking about, a decade or more, and that's constantly improving. Okay. And so thinking about the general, the behavior or the natural history of multiple myeloma, if we think about how this particular disease behaves, unfortunately for most patients, this does involve a relapse. So we've driven it down. On average, this first remission lasts several years. Many times you could expect after a transplant plus maintenance therapy, somewhere around 4-ish years. And that's a very rough ballpark. But you've now pushed the can down the road. We'll imagine we're now into the fall of 2024, and that myeloma protein returns in the blood. Ideally, it's detected before any new symptoms were to develop. So this is what we call biochemical progression, basically meaning we've erased that protein that was in the blood that was abnormal. We kind of think of as a tumor marker for the myeloma. And then ultimately it returns. And that's where you would sort of shuffle the deck, and that's why the prognosis has improved so much, because there are many, many, many other next lines of therapy that work in different ways and generally are still well tolerated. And so we can bring the myeloma back under control. And so there are unfortunately are patients that as this becomes sort of an up and down, where the myeloma relapses, we treat it. A time period goes by and those cells develop resistance, and the myeloma returns. And so this is why, even as of 2020, and despite all of the optimism that we have in this condition, this disease remains a huge, I think, obstacle in the fact that we know it has methods of getting around some of our tactics. So I kind of imagine, just like basically we just sample, let's say, an E. coli bacteria, and you expose it to enough antibiotics, it can start to become resistant to those particular antibiotics. So because of the oncology, in general, kind of learning more about the individual I would say genetics are the drivers of this disease. I expect with time we'll begin to develop some combination strategies where we can say in this particular individual, they carried X mutation that maybe is only present in 5%, 10% of myeloma patients. So maybe we use a drug X that might not work in the other 90% of patients with myeloma that don't have this condition. And then it can also tie in other backbone therapies. And so really to design treatments that are both personalized to the particular myeloma that we're treating, but also attacking it in novel ways and multiple angles, and so that we're not selecting or putting pressure from just one way. So similar to the way that, I sort of imagine the way we treat HIV, or initially this started with one medication, and we know that worked for a while, but unfortunately that virus got smart and found a way around it. Whereas nowadays, we see these very active combination therapies, and really that's where I think myeloma is kind of headed as I sort of see the future here. And so that said, in the relapse space, we've seen a number of recent approvals. I'll highlight a couple of things, and obviously we'll open up to questions as well here. So I think one of the things that's on sort of the tips of all of our tongues would be these what we call the T cell therapies, where these are immune therapies. So using our own body's immune system, our own T cells that are part of all of our protective mechanisms, that we think about this. T cells fight infections, they fight viruses, et cetera, but they also have a really very important role internally of actually keeping cancers at bay, and it's maybe not fully realize just how important those are until you take these away. So for example, in our very, very immune suppressed patients, for example, someone who's received an organ transplantation, so their body is at risk of rejecting let's say the heart or the kidney that is given. And so there are some medications that are given, for example, to lower their T cells so that they don't reject the organ. And that's a very good thing when we're trying to keep an organ alive. The unfortunate part is that sometimes we see atypical types of various cancers pop up. So things like what would have been a very benign or an indolent, let's say, skin cancer in an area of sun exposure, can sometimes become more frequent. They can behave more aggressively, and at times we see very atypical types of cancers beginning to pop up when the immune suppression is there. And so that it goes to show that the T cells do a very important thing internally, eradicating abnormal cells that we never even knew were there. So, with where we're at as of today, October 2020, really the technology has moved us into kind of this genetic engineering space where we're now able to take that normal T cell, we're able to educate it or take it to school, if you will, with some simple techniques to basically train that particular T cell, rather than to being kind of a generalist. I'm hanging around waiting for a signal from some other cell to say, we've got a problem. It is now kind of we'll say, it's something that has the ability to not only detect a problem, but actually there on the spot be the enforcer, if you will. So our immune systems generally are built in a way where it's a messenger system, where there's a recognition cell hands the baton to another cell, which then ultimately, 3 lines down ends up with sort of the punisher, if you will, the enforcer. And so this concept of what is known as CAR-T, this stands for Chimeric Antigen Receptor T cells. You do not need to remember that, but CAR-T has it's easy to remember. But basically these are engineered T cells that you can teach a T cell to go after whatever you want, but the trick is you need it to be specific enough to annihilate the thing that you don't want and to not have that happen on cells that you do want. So the selective target is absolutely the key. Unfortunately, in myeloma, these are fairly well established. The primary target right now is something known as BCMA, and these myeloma cells on their outer envelope or shell are absolutely loaded with this, and it's at about 1,000-fold higher concentration than what is on a normal cell. And so that's a perfect Achilles heel that we're looking for, that we can educate these T cells to then go after this target. And so with this CAR T cell, these are infused, because this is not a medication that the level, you imagine you take a pill and the level goes up at 12 hours and then comes back down and you rinse and repeat. these are live cells. These are part of your own body initially. They've been sort of educated, juiced up, and then given back, usually 3 or 4 weeks after they come back from the lab. And so the side effects are really, really unique. This is sort of your immune system. I would use the word on steroids with that. I need to come up with a different sort of phrase here. Steroids usually suppress the immune system, but if we say, your immune system is ramped up when these T cells go in and start to go to war, essentially, timeline-wise, many times it's 2, 3, 4 days after the cells go in, we start seeing all the things of sort of immune activity. So if you imagine, what does a flu look like? We see things like, chills, aches, fatigue, fevers. We can see blood abnormalities with things like liver enzyme, changes, et cetera. And so if we take that process and we sort of amplify that tenfold, these T cells are things that can, if you imagine the pot or the kettle sort of boiling over without proper supervision, the immune system can, I would sort of imagine that sort of nuclear reactor, overheating or sort of melting over. So we don't want 105, 106 degree, temperatures sustained over many days. Major drops in blood pressure, confusion, all these are the types of things that very, very early on, when we were really just learning how to control this, these were problems. And so that piece of it is becoming much, more straightforward with fairly standard algorithms in terms of how do you get just the right amount of T cell activity, not too much, not too little. And so we know there are some medications that can be safely given that do not affect its anti-myeloma capabilities, but can help prevent those very severe immune, side effects, especially, for example, on the brain, or these very low blood pressures, et cetera. So right now in myeloma, we do not have a commercially available CAR T cell product. These have been in the works for several years now. I believe we are about to see our first, CAR T product move into the space of something we can actually prescribe off of a clinical trial, likely in early 2021. I think the FDA will be the gatekeeper of that, but I think many of us would expect probably by late next spring we will have our first version of these types of medicines, and I think that will be a huge step forward. But just like any technology, this first construct of the T cells, is going to be continued refined, basically continually improved, modifications made to, how do we increase the activity, persistence, et cetera. So just like any technology, we'll see, major advances, and we're just at the very beginning of all of this. And so, from a CAR T angle, most of the ways that patients right now are accessing this is through a clinical trial, through, an investigation where we're really trying to study, learn how these affect the myeloma, efficacy, side effects, et cetera. So it's not something I can prescribe off the shelf, but fortunately there's been an explosion of clinical trials where for a number of the last several years, these have been in very early phase 1, phase 2 trials where maybe they're only taking, a small number of patients. Perhaps, let's say one phase 1 or phase 2 study may look at 60 patients, for example, which that's a small amount. But now that we're seeing essentially the outstanding clinical activity, as well as toxicity profiles, understanding these, knowing what the right amount of T cells to give, these are moving into later phase trials where now larger numbers of patients are able to participate, and so the availability of CAR T has widely expanded, even I would say in the last 12 to 18 months. And so this is still done in I would say centers of excellence, so higher volume centers. So generally places where you might have a stem cell transplant or bone marrow transplant, will oftentimes be the same type of place where a CAR T cell type of treatment might be offered. So at Mayo, I will say at present, we currently have 3 myeloma CAR T trials open, with a huge number of in the pipeline that are expected to really just continue to ramp up. And I think the interesting thing is we're beginning to see combination therapies, so adding layers on to say, how do we increasingly improve outcomes? So that's a little bit about the immune therapy. There's a lot to discuss there. It's sort of a talk in and of itself, but I would say on a high level, you can think of this still as positioned in a space of patients who've been previously treated who need something else. And so this will not be for patients with new diagnosis, at least for what is commercially approved. We are beginning to see some clinical trials that are now starting to ask the question of, is a stem cell transplant or is a bone marrow transplant still the state of the art in 2020? And so we will begin to see head-to-head randomized trials of patients who, for example, do their first 4 months of treatment for the myeloma to bring it under control. And then we'll see, a randomization between the standard approach, which is a stem cell transplant or that high-dose chemotherapy plus stem cell rescue, which has stuck around for the last 3 or so decades for good reason, and sort of comparing that. How do patients who actually do CAR T upfront, how do those outcomes compare? And I think it's an open question. I would love to move into the next era where we see CAR T actually, can we start curing patients at the upfront stages of this condition? So from an immune therapy standpoint, CAR T is kind of the sexy thing that a lot of people hear about. You see the pop-ups, if you're following myeloma blogs, a lot of people are very, very interested in this space because of the realities of this is a therapy that has, there are geographical limitations. Maybe not everyone can access a center where this is being given, and also this is, it's not a perfect analogy, but again, there are some increased risks here that we know not all patients, perhaps if we're older, if we're more frail, the risks of the therapy may be higher. The CAR T may not be reasonable or appropriate for all patients. So we need other ways to help augment the immune system. And some of that is via sort of off-the-shelf products. Or an easy way to think about this would be something we can prescribe. It's not a manufactured product. And so in that immune therapy space, really the best example of sort of the difference that has made, comes from the medicine that many of you may be familiar. That's known as Daratumumab, or Darzalex is the brand marketed name of this. And this is what we term a monoclonal antibody, which again, it's an engineered antibody. It's an engineered protein that's been designed in a way to specifically bind to something on the outer surface of the myeloma cell. And when our bodies have an antibody that binds to something, I sort of imagine that's if you're at the restaurant, you're sort of waving your handkerchief for the maitre d' to sort of the cleanup crew come in. So when an antibody binds to something, it naturally triggers an immune response. And what this medicine is doing when it binds to specifically myeloma cells, it's helping to generate this response. So this was approved in late 2016, initially in heavily pretreated patients. It's very quickly leapfrogged forward, where some patients now actually receive this as part of their initial combination of medications. And it's both very, very well tolerated for most individuals, and B, it's something that kind of makes everything it's paired with better. So it's if you imagine, 1 + 1 = 3, it's this synergy that we're looking for. So when you give it with some of the standard of care medications like Revlimid or Velcade, et cetera, it can help augment the responses to this. So that was I would say one of the earliest examples. But nowadays, we have a whole category of medicines that these are known as bispecific antibodies. So instead of just binding to one thing, it actually has two arms. So if you imagine sort of one piece of it is grabbing the tumor cell, the myeloma cell, and the other arm is actually grabbing a T cell, which is also sort of what we want to engage with the myeloma. And it's sort of that chaperone at the dance, bringing these two together, so that can help trigger an immune response. So those are clinical trials that are ongoing and look very promising. And I think the other angle of this is something that's termed an antibody drug conjugate. I know that's a mouthful, but we take that same basic premise of an antibody, something that binds to the myeloma cell, but then you can actually throw an extra payload, if you will, something that the myeloma does not like, and basically engineer this in a way that once the antibody sticks to the surface of the myeloma, it then internalizes this little piece, that's stuck on the end of the antibody, and just intracellularly inside the tumor cell can be released to help kill the myeloma. And so I think a Trojan horse is the perfect sort of analogy for this. It's sort of sneaking techniques inside. And so these are oftentimes used in a number of conditions. We've not had one of them in myeloma. We just saw our first commercial approval of a medication that's been in testing for several years now, and it's our first example of this particular category of medications. The name of this was Balantamab, or Blenrep, I believe is how this is now being marketed. So it's an IV infusion that works completely differently than anything we've had thus far up into myeloma. And so it's just one other example of a growing number of options. And this is what we need to be able to design individualized, personalized combinations, as unfortunately, although we call this one disease multiple myeloma, we know that many individuals have variable responses. So drug X that may work very, very well in one individual, in the next person may either be limited by side effects that are intolerable, or perhaps the efficacy is not what we want. And so being able to shift strategies is a really important thing. So this is again, those antibodies are something that are multiple in the pipeline as well, but definitely will be a huge step forward in this condition. And then if we think about really the other progress that's been made, some of these are again maybe don't grab the headlines quite as much, but I think with convenience and just thinking about impact on quality of life, since really in many cases this is becoming more of a chronic disease sort of management paradigm, factoring in the logistics of how do we receive our therapy, what are the side effects long-term to therapy are very, very key. And so this Daratumumab medicine I was mentioning a moment ago, when this was first approved, it was given as an IV and intravenous infusion, and the first several were very, very, very long infusions. So many centers actually split them between 2 days. So if you imagine 8 to 10 hours in a chair is a very long time to spend. And this was given once a week. Unfortunately, the infusions quickly shortened, but that said, it still required coming to an infusion center, starting infusion. Many people required ports and these kind of things for access. So the Daratumumab here just over the summer months was actually approved as what's known as a subcutaneous administration. So rather than an IV, this is now an injection, and so a multi-hour infusion is now shortened to about a 3 to 5 minute injection. And to me, this is kind of the having your cake and eating it too, and the fact that it works just as well as the IV Daratumumab, and that's been studied head to head. There's no difference in its anti-myeloma effectiveness, but there is a big difference in rates of allergic type reactions when you give this subcutaneously. The way this is sort of engineered is that there's a slow release, so this is gradually absorbed by the body. So the rate of reactions is about 2/3 less than if you give this intravenously. And even though those infusions were started at very, very slow rates, just drip by drip, it's going straight into your bloodstream, and so there was a much higher incidence of generally these were mild and very manageable, but reactions. And so whether that's itchy eyes, watery eyes, runny nose, sneezing, even to the point of unfortunately in less common cases of even spiking low-grade temperatures, or a cough, or shortness of breath, or throat swelling, any of those allergic type responses. That's why the infusions were given so slow under careful observation. But those risks, they're still there with the subcutaneous injection, but much lower, so much more convenient long term. Okay. And so I would say from a kind of active ways that the myeloma is being investigated across the spectrum in the United States, really the Multiple Myeloma Research Foundation, I would put a huge plug out there. They're a nonprofit institute. I'm not on their payroll. I'm in admiration of just what a powerhouse they have been in terms of bringing really just partnerships, bringing those key stakeholders to the table. So patients, for example. So the Multiple Myeloma Research Foundation was founded by a woman, as any of you may be very well aware of her, Kathy. She was unfortunately diagnosed in her 30s with multiple myeloma, and this was back in the 1990s when not a lot was happening in this condition. And she had some business connections. She was an MBA by background. And really said this is unacceptable. As she looked around, there just wasn't there were great researchers, doing their thing, but everyone was kind of in their own silo. And really what we need is partnership. And so she really kind of brought a lot of this together to one central, location. And so the Multiple Myeloma Research Foundation brought patients, also brought, for example, the pharmaceutical industry. And I know they kind of have a black eye, and perhaps for a good reason, with some of the, the pricing issues that we've run into. But that said, they've also been absolutely, I would say, fabulous in terms of bringing next generation technology and these really state-of-the-art scientific methods to both design medications that work in the way that we need them to against myeloma, but also designing really critical, important, trials to help us answer questions of, how do we improve long-term outcomes? So bringing, pharmaceutical industry, and then also researchers, and so kind of getting everyone at the, at the same table. So Multiple Myeloma Research Foundation, I think, to me, is the ideal, if we were saying, other sort of tumor types, breast and lung, et cetera, to me, kind of looking to what the Myeloma Research Foundation has done. It's a great paradigm, great model. And so one of the things right now that really is one of their top level, high level initiatives is something that's called the Cure Cloud. And again, many of you may have kind of stumbled across this, but really what this is trying to do is bringing genetic sequencing, genetic information that right now is still in a very, very small percentage of patients that we get deep, high resolution genetic testing in. And this is specifically in the myeloma, not your normal bloodline that you got from mom and dad. These are acquired abnormalities. And really trying to understand, how is this myeloma behaving? How is it gaining a growth advantage, and how do we target that? And I think with myeloma, Dr. Bergsegel, one of my colleagues that many of you probably know, sort of likes to joke that when, essentially multiple myeloma was named, if you sort of think back into the 19th century, they kind of stumbled upon, brilliance in the fact they were describing what they saw to the eye, which was that in places like the bones, there were multiple, tumor collections that they called myelomas. So multiple myelomas makes sense. But really, once we know on a genetic level what this looks like, as I kind of alluded to earlier, Mr. X may have very, very different genetic rearrangements than Miss Y. And so, compared to some types of blood cancers, there are some types of conditions that 99% of people with disease X all have the same mutation. It's one of the ways we make the diagnosis. I think when we first learned about the genetic information coming back in myeloma, there was probably a collective sigh of perhaps sadness, despair, if you will, because I think we were all hoping for that silver bullet. And I think clearly the story we have in myeloma is that is not the case. So it's going to take tailored therapy. But to really move that personalized therapy into the next step, you need to know what's there to begin with. You can't fire fire arrows into the dark, if you will. And so this what we call the Cure Cloud really is helping to bring that information on a high level, looking at very large gene panels, 70 gene panels, but this is going to continue to evolve as we gain information. And I think the other brilliant piece of this is, as the technology gets more sensitive, it's looking to gain this information from the peripheral blood. And so I will be a happy camper the day that we can ideally get most of the information we need on a day-to-day basis from blood tests rather than bone marrow biopsies, which right now, if we really have to get DNA, which the genetic sequencing, of course, requires, for the most part, we do need to go to the bone marrow to get enough cells to run the analysis. But as that technology improves, that I think will also be a huge step forward. Okay, so I know the format wise, I've got a couple of questions here. And I will, I'm kind of looking at one of these. And so I see a question here, and this is, how do you treat the patient with a pancreatic myeloma? So essentially a myeloma that has involved the pancreas, which is an uncommon manifestation for this. The question is, do you have the patient perform a Whipple surgery before other curtailing chemotherapy? So essentially, do you do medication type treatments to basically knock this down, or do you do a surgical extraction of this, perhaps followed by chemotherapy? And so let me just take one quick step back. So this is, if we start talking about myeloma that is outside of the bones or bone marrow, we'll commonly use a term of what's known as extramedullary, and that's referring to it's outside of the bone marrow. And so historically, extramedullary myeloma tended to be something that occurred, let's say, after multiply pretreated, myeloma is, let's say, evolves over many, many years, and rather than lytic lesions or these sort of punched out spots in the bones, it can start showing up in atypical places. And so these would usually be areas of the organs or soft tissue. So for example, the liver or the gastrointestinal tract, or our upper airways, and sad scenarios, unfortunately, this can go to the nervous system or the brain. And so these are uncommon manifestations, but historically have been a marker for high risk or sort of badly behaved myeloma. It applies to the minority of patients, but it's usually a marker for, more aggressive or fast growing myeloma. So that's to say extramedullary myeloma for most patients happens towards more advanced stage or sort of later on in the disease journey. The other angle on this is that this can also show up in an isolated tumor, that when we look at the rest of the body, for example, we look at the blood or we look at the bone marrow, or you do a head to toe scan and you don't see anything else except one tumor, one mass. And this can happen in many, many places. The pancreas is one of those spots that we can see this, where if you just look at the scan, maybe our radiologist would say this looks like a pancreas cancer. The sort of the normal, when we think about pancreas cancer, pancreatic adenocarcinoma, which is a very different beast. But on biopsy, sometimes we're surprised and you say, aha, these aren't pancreas cells. These are myeloma cells. These are plasma cells, which normally live in the bone marrow, but we do have very, very low concentrations of them, throughout our tissues, especially in places like our digestive tract, our upper airway, our bladder. And so at times it's the tissue sort of specific. So something that's hanging outside of the bone marrow, one of these tissue plasma cells, that becomes a problem and develops an abnormality and forms a localized tumor. And rather than it being kind of a liquid tumor floating around in the bloodstream, it's something that's specifically adherent to that one spot. And so plasmacytoma is a term that's used for this. And so plasmacytoma can be treated in many, many different ways. And a lot of this really depends on where it is located. For example, in plasmacytoma of the bone, so a solitary plasmacytoma of the bone, these are generally very, very radiation sensitive. And so our radiation oncologist will generally become involved, may give roughly 5 weeks of targeted radiation therapy to that one spot with the goal of cure. And about half of patients actually never need to receive medications. Basically you sort of imagine the problem was just that one area, and by doing local therapy, you can address it and eradicate it. In trickier areas, sometimes, for example, the base of the skull, et cetera, the radiation can sometimes be a little bit more sophisticated. And so our radiation oncologists now have some more sophisticated ways to really try to stop those beams or make that beam as precise as possible. And so some of you may have heard of a term that's known as proton beam. Historically, radiation, when you hear people talk about it, these are photons, and not that you need to study physics 101, but a photon is a heavier particle. You could run it straight through something, but you can imagine, kind of like a bullet passing through something. You can't stop it, and so whatever is sort of behind it is unfortunately going to be collateral injury, even if you don't want the radiation to go there. So as we start talking about very sensitive tissues, base of the brain, eyes, nerves, etc., proton beam is a newer technology to be able to give effective radiation, but also spare some of those collateral tissues by really being able to hone this in almost in a sort of pencil-like tip of a pencil fashion. So proton beam is being increasingly used in those select tricky places, and surgery absolutely can be used in areas where either giving radiation just as tricky, and historically the GI tract, again, kind of the bowel, pancreas, glands, these types of places can be challenging areas to radiate because of the fact that just the injury to the tissue, the scarring or fibrosis or what we term mucositis can be more profound in those sort of very fragile areas. So sometimes surgery would be an option. And so, a Whipple surgery is a it's a very involved surgery. This is something that requires quite a lot of recovery and definitely needs to be done in experienced hands. So we wouldn't take that lightly. This is not a chip shot surgery where you're walking in and walking out. There's a lot of recovery that's involved with it. So you'd have to really weigh the options. I would probably need to know a little bit more about the other I guess anatomical factors and what else is going on in that situation. So I would say commonly radiation for an isolated tumor just in one area that we call a plasmacytoma. Radiation is usually the first stopping point. The second option would be a surgery. And so, for example, in the sinuses, absolutely, that ear, nose, and throat doctors may go in and resect that area. And depending on if they felt confident they got it all, we can go in and sort of do what we call adjuvant therapy or post-surgical treatment, radiation to sort of sterilize that space or clean up that spot. And then on the third level, if let's say again this was a plasmacytoma, it started in one isolated area, we treat it, and in that unfortunate scenario, let's say a couple of years down the line, it comes back and it's in a slightly different place, but we're now talking about multiple areas in the body. That is where still medicines can be very helpful. That even if you don't technically have myeloma that's floating around in the blood or in the bone marrow itself, some of the medications can be very, very effective at eradicating those areas or tough to treat spots. And so I can think of a scenario, for example, where a very persistent plasmacytoma that had fallen unfortunately in the bladder. And so the bladder, you kind of imagine, it's this little balloon that's expanding, it's shrinking, contracting all the time. And so anything that's irritating the bladder wall tends to generate this urge to urinate. And so this bladder wall plasmacytoma had been treated with radiation, got better, unfortunately recurred, treated with more radiation. Still present, very severe voiding symptoms in terms of waking up all night long with this urge to urinate, even though the bladder wasn't full. It's just the bladder is injured. And so in that scenario, we used a medicine that historically be used for myeloma called Revlimid, and this was after the patient was offered what's known as a cystectomy, which was basically go into the belly, take out the bladder, rehook all the plumbing into external bags, or sort of draining the catheters external, or draining the urine externally through catheters. And so that was what was offered to him by the surgeon, and it's very reasonable that would have taken care of it. But we said maybe maybe we kind of pump the brakes on this a little bit and say, are there some medications that can actually get us to the same place, just different way to make the cookies, if you will. And so in this scenario, the patient exceeded my expectations, but honestly, within a week of being on a pill a day, started noticing his urine was becoming a little bit funky. He was saying, gosh, it kind of had some debris and some just kind of almost looked like sediment in the urine for a few days. And then it passed, and it was back to normal. And very, very quickly thereafter, started noticing that, I've gone 4 or 5 hours without having to urinate. And normally we were talking, every 15, 20 minutes during waking hours with this urge to go. And essentially on relook 3 months later, all of the bladder tumor that was previously there was completely undetectable. Life is normal again. So so that's just to kind of go to show that, I mean, there's you got to sort of weigh all of your options. We have multiple tools at our disposal and really trying to kind of say what makes most sense in any particular situation. Okay, and so kind of from the same gentleman tying into that same question, I'll just read this out loud. It mentions that from the support group meetings, that essentially, some patients are living over, 2 decades. Let's take a look here. Sorry, I'm just trying to make sure I understand the question here. You should learn new knowledge of cancer treatments from finding similar. Okay, so yeah, so I think basically it was highlighting the fact that many patients are living for much longer periods than perhaps what maybe they were initially that very first conversation when they were diagnosed. Say going into the early 2000s, for example. And they're given an X amount of time, and perhaps we're told you have a few years to kind of get your business in order, if you will. And then sure enough, the science changes and we have a breakthrough medication. And so that in and of itself completely changes the prognosis. And let's say that holds the myeloma, under control for unspecified amount of time, but we'll say a couple of years. The science changes, a new medication that attacks the myeloma in a different route comes along. And so Dr. Ken Anderson, who's at the Dana-Farber in Boston, who I would say has been really one of the sort of the elder statesman of multiple myeloma. He's been at this for many decades, and his lab and his investigator team really has been absolutely essential in bringing some of these treatments that, as I was coming up in the ranks, were termed novel agents. They're not very novel anymore if we think about many of these sort of landed on the market 2004, 2005, but at that time really ushered in a brand new era of therapy. But he oftentimes likes to point out, there were some of the patients that were very first, they were, if you will, kind of very early adoptees of some of these medicines on clinical trial. And there's one particular woman that I believe the running tally was, she was on year 19 of Revlimid. And when she started the medication, the drug did not have a name. But it's been sort of the wonder drug for her. I wish everyone got 19 years out of that particular medicine. Obviously that she's the minority, but this was someone who had been multiply pre-treated, and so sometimes he likes to talk about that. People say, just keep me chugging along, keep me healthy until the next big thing. And I think I think there's honestly some truth to that, and the fact that the science is moving forward very quickly. And I think some patients, for example, ask me, doc, what would you treat me with when my if and when my myeloma comes back, let's say 4 years from now. And the honest answer is, if I sort of think back to what I was doing in October of 2016, there's maybe some, there's a basic similarity to many of this, but there are some huge steps forward that I can kind of think back to 2016. We do completely differently, and I really think that sort of trajectory, or the rate of change, is actually accelerating as the science and the technology just gets so much better. And so, I think using the tools at our disposal, maximizing benefits. So transplant is a perfect example of that. It's a known. It's not sexy, but generally with transplant, we know that we can help control the myeloma with sort of one fell swoop, one big heavy duty dose of myeloma for most patients, which will sort of put it in sort of a remission, or into a dormant period where it's not causing bone injury, it's not causing kidney injury, et cetera. And so in that time, the whole period, the science is accelerating. And so by kind of giving yourself, that period where you're not reaching back into the toolbox to use other medications, kind of allowing the science to move forward and improve with some of the tools at our disposal. But without a doubt, I think we're just at the very foothills of sort of a mountain of progress here in the very near future. I kind of think back to my early days, internet arriving, and sort of the dial-up internet, all that good stuff, logging on to American Online, AOL. And as a kid, maybe you don't realize that you're living in the middle of a revolution, but that was sort of the internet revolution. So when you're in the moment, you don't necessarily always feel it. Myeloma, we are absolutely, we're kind of in what I would say is a similar phase, in the fact that CAR T, these types of things, we are seeing unprecedented responses, unprecedented rates of basically response and success with this, and we're just at the very beginning of this. So just like the internet, CAR T right now is dial-up internet. So it is a huge step forward from pre-internet, but that said, we're going to see huge step ups in terms of efficacy, persistence, in that particular technology. So we're just at the very beginnings. I have a couple of, I'm not going to bombard you with slides, but I have a couple of I would say summary. Let me just pull this up here. I apologize. A couple of summary outcome composite things that I'm going to switch my screen over here, that summarizes really what we're seeing with myeloma in terms of CAR T response rates. So pardon me, just give me 1 second. I don't know where my Zoom window went. I somehow minimized this. I apologize. Here we go. Okay, so just very quickly, this was a This was a recent clinical trial that Mayo Clinic did participate, along with a number of other centers of excellence across the United States in multiple myeloma. It was coined the CARTITUDE, 1 trial. So it was a phase 1, phase 2 clinical trial looking at what we know as relapsed refractory multiple myeloma, meaning relapsed, the patient has been treated, their disease responded, and unfortunately came back, so it's relapsed. And refractory is using a term trying to designate that certain medicines that previously worked, unfortunately, have stopped working. So the patient has developed resistance or refractoriness. So medications like Revlimid and Velcade, et cetera. So these were patients who had used standard of care, agents who went on to this particular clinical trial. So this is a CAR-T study. This doesn't yet have a full name. The shortened version of this is over here. Again, you don't have to remember this. But the thing that I would highlight, and as an oncologist, you don't see these kind of results very often in therapy trials. ORR is referring to objective response rate, which basically means, did someone develop clinically significant benefit from this medicine? And again, this was a very small phase 1 trial. The N, or the number of patients participating, was 29, so small. That said, 100%, so 29 out of 29 patients saw their myeloma improve. And to define this basically means their M spike, or their myeloma protein in the blood or the urine, dropped by 50% or more. So that's significant. What I think is even more remarkable than that, as good as that gets, the part that absolutely blows off the barn doors is that, I will say, historically with myeloma in a patient population who's been extensively pretreated, we see a lot of what we call partial responses. The M spike drops, let's say it goes from 4 to 2, we plateau, and unfortunately at some point that number starts rising again. Very few patients entered into a complete response in the later phases of their disease, unfortunately, just as the disease becomes more refractory or tougher to treat. So what we're seeing here, this SCR is kind of the highest of the rungs on this ladder, if you will, as you're climbing. So basically this starts at the bottom. So the PR, partial remission, partial response. So 3% of patients of this 100 saw that their myeloma proteins dropped by 50% or more. 10% of patients saw that it improved by 90% or more, which is a term we know as VGPR, very good partial response. So you're deepening the response. But this big purple, a chunk of the graph here, stringent CR, which basically means in the blood, in the bone marrow, in the urine, that we cannot detect the myeloma on any of the most sensitive methods. And so 86% of patients entered into the highest, most sort of exclusive, form of remission in a patient population that's refractory to the standard of care. This is completely unprecedented, and I can't emphasize this enough. And this type of a trial, historically, if we saw a response rate, meaning number of people who benefited on a phase 1 trial in multiple myeloma for patients with this type of makeup, 40%, 30% even is enough for people to kind of get a pat on the back and say this looks promising and deserves further study. That said, less than 10% of patients historically on this type of a trial, a relapsed refractory patient population being studied, less than 10% of patients enter into a remission state. And so we've kind of completely turned that on its head. So instead of 10% of patients achieving a remission, we're seeing about roughly 10% of patients not achieve a remission, and the other 90% do. So it's this is the kind of stuff when I sort of sit in the audience, or you're seeing patients be treated with this, you realize the power of these types of therapies. And so again, we're at the very beginning of this. CARTITUDE 1 has led to CARTITUDE 2 and 3, so these are now larger studies. These are actually just beginning to kind of enroll. So I just wanted to kind of bring this out because this is the type of thing you don't see very often in oncology. So again, kind of going back to this, the revolution, if you will, or the transformation of how we treat this disease. This is really, to me, kind of the first shot of it, if you will. Okay, so I'm gonna stop sharing here. We'll come back down. So I've got a couple more questions. So I will summarize this here. Okay, so this is a little bit of follow up from the past history. So we have a patient 52 years old, diagnosed with myeloma, specifically in the pancreas, that had grown over a number of period of time, that is now extending into the pelvis. She was treated with what we'll call a triplet combination known as VRD, that many of you are likely familiar with: bortezomib, lenalidomide, dexamethasone, or Velcade. Revlimid dex is the other name of this. Some maintenance therapy, then ultimately stopped therapies. And looking at outside oncologist is asking essentially, blood work every couple of months for surveillance. So perfect. Yeah. So I mean, this is outstanding. So I mean, I think this is the kind of story that I absolutely love to hear. I mean, this is an atypical presentation of myeloma. But that said, I think having a goal at the very beginning of treatment, I think, is absolutely essential. And I kind of hinted at this a little bit earlier, but I think one of the things that still, to me, is sort of one of the obstacles, but I think this is something with a solution that can be fixed, is having techniques that can basically giving you objective data, something to measure to help guide your therapy, as if we're basically calling patients with myeloma in response, or in what we call complete response or complete remission, which has historically been defined by routine techniques of looking in the blood for that M spike, looking in the bone marrow for some, looking at the pathologist, under the microscope, for example, can they find cells? And if they don't, they call it remission. Well, unfortunately, patients essentially across the board recur, so that we know that is not telling us the whole story. So many times, you've probably seen that little diagram, of the iceberg model. And so, there's what you can see above the surface, but we need to be able to dive much, much, much deeper. And so one of the ways that really, is state of the art over the last several years, it's being increasingly used to tailor therapy, is this molecular test that there's several of them out there. There's different ways to do this, but the category is what we call MRD testing, or minimal residual disease, which is kind of this deep dive now down to this roughly about 1 per million cell in the bone marrow where you can find this. And so, without a doubt, in our patient population who, I would say are in a place where they're able to tolerate, for example, modifications, or adding, let's say, if we're on a three drug combination and we're making progress, but we sort of hit a roadblock, can we add a fourth medication based on tolerance, just medical health, et cetera, and patient philosophy. I think I have some patients who would tell me, doc, I want as few of side effects as possible. And I have others who would say, I'll throw your best stuff at me, as long as sort of the end goal, justifies the means. So I think everyone has different philosophies, with this, and that's where I think, it's important to have that partnership, with your treating doctor, and the patient, to make sure everyone's on the same page. But I think you wouldn't set out on a road trip without navigation, without an end destination. So, I think it's someone who, for example, is transplant eligible, is fit. I would say really as of kind of current day, MRD negativity, I think, is an increasingly used sort of goal to shoot for. And that basically means that by these even more sensitive methods, we can't detect the myeloma even by a molecular test that can be picking this up on a much more sensitive method. So in this particular case, I think this highlights that essentially, we had a tumor that was unfortunately growing, started with sort of, best players. You put it in the big guns, early on. And once you've seen that stringent remission, or you've sort of eradicated the myeloma, you're able to back off to a sort of a low intensity, therapy that, basically is term maintenance. And there's many different types of maintenance that one can think about. And a lot of this depends on, again, kind of side effect profile, how well do we tolerate these kind of medicines, and also how well did it work. So oftentimes you sort of pull one of those medications that was used up front and modify, let's say, the frequency of administration, giving it less often, or the dosage, so giving a lower amount. We just don't need as big of a hammer. And so shifting over to maintenance, and then, at some point, when we see long periods of remission, the goal is not for us to treat patients indefinitely and be on something forever. I would absolutely love to be able to have that conversation to say, your myeloma is cured, it's undetectable, we can stop therapy. And I think one of the things that will help allow us to do that is just more and more sensitive methods. And so MRD testing is one of those ways that's a step in the right direction. It's not perfect, but it's really, I would say, one of our most powerful prognostic marker, as of 2020, and it's physically, it's here. It's not a pipe dream. And so we can say in our patients, especially with what we call sustained MRD negativity. So we've done, let's say, treatment X. We have eradicated the myeloma to the point we can't detect it. We get an MRD negative test result on a bone marrow biopsy. Many times we may decide for various reasons to stay on therapy for a little bit longer. So let's say we're post 1 year of treatment, we're MRD negative, and we say we're going to push on for another year. This is not scientifically based. I'm making up a model here, but essentially, let's say then at the 2-year mark, we now repeat that same test and we see the same results. So sustained MRD negativity. So this is all being increasingly, I would say, sorted out. But we know MRD negative on one sample is a very, very good thing. If we're able to sustain that over time and repeat it, and see the same thing even as you're again kind of moving up the escalator in terms of response. That's now the holy grail. And so clinical trials, for example, are now being designed in a fashion to ask the question: who are the patients who do not need to be on maintenance therapy, who may be functionally cured, or at least have extremely long periods of treatment-free intervals of remission where they're not exposed to medications. And if we're seeing very, very long, excellent periods of quality of life without medications, that's the ideal scenario. But really, we need to know, how does that affect the behavior of the myeloma, making sure we're not impacting, long-term survival. Because obviously, if let's say, putting up with a little bit of side effects leads to long-term, we see increased survival by staying on low intensity therapy, then perhaps you make an argument for maintenance therapy. But that said, if you can say in those folks who've hit a home run with their treatment, they're MRD negative, you're watching treatment closely, you're on surveillance with either blood tests or imaging, and likely a combination of all of the above. As long as you're watching it and things look good, then you have this sort of runway in front of you where we don't have to treat necessarily. And I think that's all of us, and I know my colleagues here at Mayo and many of the myeloma experts across the world really, I think, would love to see myeloma go to this area. I kind of imagine to where we've come from, where we had many more kind of fixed duration type of treatments, where essentially you did 12 months of treatment, you did 18 months of treatment, and then things came to a stop. Or after a transplant, you did a transplant, and then there was no therapy thereafter. We've sort of gradually slid, I would say 2014, 2015, with some of the trials that showed that these maintenance therapies help patients live longer, keeps the myeloma, under control better than if you sort of wait for the myeloma to get off track and try to sort of rope it back in. And that led to a big paradigm shift. But I think from a patient level, I think quality of life wise, many of you are very, very familiar with the fact that, these medications, there's sort of there's a bit of a trade-off in terms of things like fatigue and, GI symptoms, and, there's the financial cost, which is a whole different, ball of wax. So I think big picture, these are, to me, having a roadmap. This is our goal. So MRD negativity is a great thing to shoot for, but I think this will continue to evolve as we get better molecular, more sensitive laboratory tests. And B, for example, when we get to that point, when can we stop therapy? And those things are actually being looked at actively right now. So a follow-up question. So we have a question about neuropathy, gabapentin. So I think it's a fantastic question. Unfortunately, it is a reality. Neuropathy is a big obstacle, and this comes from not the disease itself generally, but unfortunately because of manifestations of the disease, manifestations of the medications we use to treat the disease. So classically, the medicines best known would be Velcade, these types of medicines, but drug-induced neuropathy is common. So absolutely, some of the analgesics, things like gabapentin, another one that's been studied as a medicine known as Duloxetine or Cymbalta, these absolutely can have benefit. They don't reverse the neuropathy, unfortunately. So the biggest thing is sort of what Ben Franklin said, sort of that, ounce of prevention is a pound of cure. If we're on a medication that's causing signs of neuropathy, to sort of, if at all possible, change treatment before it's severe. and that takes some clinical recognition. And on the other side of it, you know, for example, if we're dealing with neuropathy that's you know, problematic, what else is there? What else is there out there besides kind of traditional medications? And I think this is where it is sort of a, you know, some of this is anecdotal evidence. I don't have large phase 3 trials, but you know, without a doubt, sort of massage, acupuncture, these types of things, many people do pursue, and I think it can without a doubt be beneficial. You know, I think maintaining good circulation, so exercise, getting the blood moving, getting the lymphatics draining, all of these kind of things that sort of the nerves need to heal, you know, is something that's helpful. You know, and I think last last resort would be, you know, scenarios where the, you know, the neurologists are getting involved. There could be neurostimulators and, you know, a whole number of other things in severe cases. But you know, I think ideally we're getting to a point where we're not using medications that are injuring the nerves, and so, you know, that's where some of the push, for example, substitution of this medicine called carfilzomib, which is a close relative of bortezomib, or known as Velcade. These hit the same target on the myeloma, but much lower incidence of neuropathy. So can we find agents that are just less prone to cause it? So that should evolve with time. So I think we're getting close to time went fast, but essentially. Any other lingering questions before I let you enjoy the rest of the afternoon here for anyone in the audience? Okay. All right. Well, if that is the case, I appreciate you know, everyone's you know, basically everyone's participation here. It's great to have you all, and I hope you kind of gleaned a few things from this. And I'm sorry we're not in 3D and you know, be able to be, you know, in the same room together. But again, all things considered, lots to be, I think, very optimistic about, and this is a disease that's reinventing itself constantly in terms of how we're addressing it. So, lots of reasons for optimism. So, with that said, thank you all, and have a wonderful evening.